In this part 2 of pharmacologic pain management strategies, I'll discuss opioids and other analgesics. So we'll talk about common opioids used to treat pain and some other analgesics that are used for refractory pain. I'll discuss briefly opioid rotation, titration, and the treatment of breakthrough pain, and briefly describe keys to effective implementation to optimize pain management. I would highly recommend that you review the National Comprehensive Cancer Network's Adult Cancer Pain Guidelines from 2019 that contain more information. So when would we consider a trial of an opioid? This is when we have people with severe acute pain secondary to injury or trauma, or chronic disabling pain that's not been responsive to non-opioid therapy and non-pharmacologic measures, and pain secondary to serious illness such as cancer with cancer-related pain that's not controlled on non-opioid therapy. So we'll go back to the case study that I brought up in part 1 of this module. ML was originally treated with non-steroidal anti-inflammatories that were efficacious for the pain to the vertebral spine, no effect on the facial, hand, or foot pain, and eventually could not tolerate them due to gastric distress. She was then treated with anticonvulsants, which relieved some of the neuropathic pain to the hands and feet. She continued to have severe pain secondary to the vertebral metastasis that was refractory to corticosteroids, and thus opioids were a consideration. So when we think about the treatment of opioids, we're looking at the use of opioids for moderate to severe pain that's refractory to adequate pain management with non-opioids. And this has really changed over time where, 10, 20 years ago we were using opioids for anyone that had severe pain, regardless if they had cancer or not, and we're really rethinking things. And we're having to think about this in people with serious illness too, like, what is the best dose of opioids? Should we continue opioids? There's no uniformly preferred agent. There's a lot of individual variation in response to the agent, so rotation may be necessary. And when you're selecting one opioid over another, it's really clinical judgment. What is on the formulary, especially when we're looking at treating people in the ambulatory care setting? What is the cost? Or is in the inpatient setting, is there a parental formulation? If we are thinking about treating people in the ambulatory setting, because remember there's a lot of people with cancer or advanced heart disease, lung disease that may require opioid therapy that are not imminently dying, then we need to think about using opioid risk assessment, cautious prescribing, and implementation of safety plans at home, which won't really be discussed in this lecture but are available in other lectures. So this is a not all-inclusive opioids that are commonly used in serious illness. Again, you may be using different ones in your setting. I'm going over the most commonly used ones. Now, morphine has the longest history in the treatment of pain, and it's usually considered to be the standard for comparison across opioid medications. And around the world, it is the one opioid that's more universally available, although in many developing nations, even morphine may not be available. So it's available in multiple formulations, orally, short, or modified release. I'm using the word modified release here, but you may think about it as controlled release, extended release. Intravenous, epidural, intrathecal, rectal, and it can be concentrated liquid 20 milligrams per 1 ml that's useful at the end of life. Now you'll see I don't have sublingual there, although that's listed as a formulation. And yes, when someone is close to the end of life, you may be using the 20 milligram 1 ml and putting it sublingually. But it's found that it probably doesn't absorb any better this way than if swallowed. And the bioavailability of morphine is only about 30%. It tends to be the first tier of prescribing due to the comfort level of providers, due to cost, is one of the less expensive, and due to formulary restrictions. So when I'm working in the ambulatory care setting and I'm going to start someone on an extended release opioid, if I want to use, say, an extended release oxycodone, I may have to show that this patient did not tolerate extended release morphine. And it's something to think about if you're working in the inpatient setting and someone started on an opioid and you think that they're going to go home, they're going to be seen in ambulatory care. What is the choice? Yes, you might be able to use that extended release oxycodone in the hospital setting. It may not be covered by the insurance in the ambulatory setting, or the copay could be prohibitive. So morphine does have some active metabolites, morphine 3-gluconaride and 6-gluconaride, which are renally excreted. So obviously the accumulation can cause increased side effects such as sedation, agitation, and confusion. So that means we have to be careful with the use of morphine in renal insufficiency and renal failure. And remember, changes in renal function in advanced disease can happen even with a normal creatinine. So it's something to be aware of. An alternative to morphine is hydromorphone. It's significantly more potent than morphine, and it depends on what equal analgesic dosing chart that you look at to tell you. I tend to say orally it's about 1 to 3, from oral hydromorphone to oral morphine. People say differently. It's available in short and modified release, intravenous, intrathecal, rectal, and it can be concentrated IV at 10 milligrams to 1 ml, which is really useful for subcutaneous infusions, especially say if we have someone that's home toward end of life with subcutaneous infusions. It may have active metabolite accumulation on high dose long-term administration, and you might start seeing some myoclonus. Now, oxycodone, probably everyone's familiar with it because oxycodone with acetaminophen, is often used for acute pain, short periods of pain. The extended release opioid, I think most of us know about just because of all the controversy that came about with the increase in opioid adverse effects, and a lot of blame was placed on oxycodone extended release for being part of the problem that contributed to the current opioid epidemic. Its equal analgesia is somewhere 15 to 20 of oxycodone is equal to 30 of morphine. Rectal and IV are not available in the U.S. I'm going to tell you it's very often prescribed by the oncologist I work with for first-line prescribing for when they're starting pain management. I tend to try to avoid it. I do find that some people don't tolerate it as well because there is some, not only mu agonist, but some kappa agonism that seems to increase side effects. And also, like I said, the controlled release or the extended release formulation may not be first tier on that patient's prescription plan, and thus could be quite expensive or require excess prior authorizations. Now, fentanyl is a synthetic opioid. It's highly potent, highly lipid soluble. It's about 100 times more potent than morphine. So 100 micrograms IV is about equivalent to 10 milligrams IV of morphine. It has no PO bioavailability, so available intravenous, neuroaxial, transdermal, oral, transmucosal, nasal, sublingual. It tends to be well tolerated in old, frail populations and empirically recommended when someone has renal insufficiency. In the IV form, it has a faster onset of morphine than morphine, but a shorter duration of action in single doses. However, it can store in adipose tissue and can lead to prolonged half-life. More recently, people might express a lot of fear if you mention fentanyl, because most of the opioid overdoses that we're seeing at this time, this is recorded in 2022, are secondary to fentanyl, but this is illicit fentanyl that is probably more than 100 times more potent than the fentanyl that we prescribe in the medical setting. Now, the fentanyl transdermal is something that people use widely. Again, I think about using it if someone can't take oral well, they're on a stable dose of opioids. I find it harder to titrate up when I'm trying to find a dose, and know that even though it's dosed at every 72 hours, you may need to change it every 42 hours due to end of dose failure. And what I didn't mention with the hydromorphone, the morphine, and the oxycodone extended releases, that even though they may be dosed every 12 or even 24 hours, you may need to shorten the interval secondary to end of dose failure. And end of dose failure is different than breakthrough pain. It's when that if a medication, so for example, the fentanyl, the patient says to you, it works great the first 2 days. The third day, I feel like I'm not getting pain relief. That's an end of dose failure versus the patient saying, when I try to do my physical therapy, I have an increase of pain, but otherwise my pain is controlled. That would be breakthrough pain, which we'll talk about a little bit later. Now, the fentanyl oral transmucosal or intranasal are rapid onset opioids used for breakthrough pain. And there's multiple formulations that are not dose equivalent, and it's not to be used in someone who's taking less than 60 milligrams of morphine equivalent daily, which is termed opioid naive. And so it's quicker onset than, say, if we use immediate release morphine or immediate release oxycodone. I feel like it's probably less utilized than we could, partially because of formulary restrictions. You may not have it on the formulary in your hospital. As a prescriber, I have to fill out certain risk evaluation mitigation strategy forms that the patient also has to sign, and this was partially because it was inappropriately prescribed some years ago for non-cancer related pain, and there were some morbidity and mortality associated with that. Now, fentanyl can be used subcutaneous, but it tends to cause erythema and duration, so it's not well tolerated. Methadone. Now, if you are a prescriber listening to this, may not be prescribing this unless you've really worked in palliative care or pain management or you consult with someone. But for those working in an inpatient setting, you see someone come in with methadone. Remember, it's an inexpensive, effective opioid with unique characteristics. It actually may be more effective for neuropathic pain secondary to the NMDA antagonism, which may reverse some tolerance. It may produce analgesia in pain syndromes that really have not been responsive to other opioids. It's available in so many different formulations. It has a really high bioavailability, almost 80%. And because it is a longer acting opioid, it actually the liquid formulation can be used in enteral tubes, like your gastrostomy tubes, to provide extended analgesia. Now, remember, methadone is also used for opioid use disorder through an outpatient treatment program. So if someone comes into your hospital setting on methadone, how would you know if they are on this for opioid use disorder versus pain? Well, one, the patient may tell you, but two, if the patient's taking it once a day, it's probably for opioid use disorder, because the analgesic action of methadone really only is 6 to 12 hours, where when you're using methadone to treat opioid use disorder, it's once daily to prevent cravings. Now, it has a long variable half-life. Typically 24 hours, can be high as 60 hours. I've seen in some literature even as high as 150 hours. It can accumulate then and cause excess sedation 3 to 5 days after initiation or increasing the dose. And that's why we don't titrate the dose as rapidly as with other opioids. It also has a lot of drug interactions because of its metabolized through the P450 cytochrome system. And we have to be really careful when we titrate medications or we add or discontinue medications. And really have to make sure the patient tells other healthcare providers in other systems that they're on methadone, because things like something like fluconazole, for example, used to treat for example, Candida, can actually, in combination with methadone, double the effect of the methadone in the system. So really, really important. It also can cause EKG QTC prolongations, which can lead to torsade de pointe, fatal arrhythmias. And so usually you're going to attain a EKG prior to initiation when you're titrating doses, or when you think you are using other medications that can prolong the QTC, such as tricyclics, neuroleptics, antiemetics, antipsychotics. The use should be limited really to clinicians that are educated in its properties, and it really should not be used for breakthrough pain. So, and when we're thinking about rotating to methadone, there's a lot of different formulas that are used, but generally you're almost reducing the dose to by about 90% and not titrating more than every 5 to 7 days. Now, many of you may have never even thought about the use of buprenorphine for pain, but it is a Schedule III controlled substance. It's a partial mu receptor agonist, but it can still provide full analgesia, but less opioid-related adverse effects. It works on multiple other receptors, such as it's a kappa receptor antagonist, which can reduce dysphoria, depression, anxiety, decrease addiction risk. It's also a delta opioid receptor antagonist, so limits the impact on GI motility, respiratory depression, and it can also work more with analgesia in the dorsal horn, so reduces tolerance and addiction potential. It is available as a patch or buccal buprenorphine that is FDA approved for pain. And with the buprenorphine patch, which starts at 5 micrograms per hour, it's a once weekly patch that's equal to about 10 milligrams of morphine daily. And so it actually has a ceiling effect for respiratory depression. So meaning even with higher doses, you have less risk for respiratory depression unless we're using other agents like benzodiazepines with it. So again, the patch or the buccal low dose are FDA approved for pain and those that require around-the-clock analgesia and may be opioid naive. Now, this is not to be confused with the high-dose buprenorphine, such as you hear talking about Suboxone, Subutex, that is approved for the treatment of opioid use disorder. You would never use this in someone who's opioid naive, as the lowest dose is 2 milligrams. And depending on what conversion table, some people say buprenorphine 1 milligram is equal to 30 milligrams of morphine. Others say 1 milligram is equal to 60 or even 100 milligrams of morphine. You would never use this in someone who's opioid naive. However, it can be used off-label, meaning not FDA approved for pain. And I use it in several of my patients who have serious illness, pain secondary to cancer or advanced disease, but also have a risk for substance misuse. Now, the things that we don't want to use in pain management: codeine. It's for mild pain or cough, and it's often used combined with like acetaminophen, like Tylenol with codeine. It's metabolized to the CYP452C6, which means it has to be converted to morphine for efficacy. So if you have a poor metabolizer, you have no pain effect but increased adverse effects. But with rapid metabolized toxicity could cause death, and we did see this with some women who were breastfeeding infants being given codeine, and the rapid metabolism could cause opioid-related severe side effects for the patient and, in this case, the infant. Meperidine, hopefully none of you have this on your formulary anymore. It's not recommended for any type of pain due to the potential toxicity from metabolites. Now, the considerations for opioid initiation in ambulatory care. For those of you that work in ambulatory care and APRNs that may be listening to this lecture, there is other lectures that talk about safe opioid prescribing, But obviously, we have to think about a comprehensive pain assessment. We want to do opioid risk assessment. And again, these are available in other slides. You want to clearly document a treatment plan. You want to use urine drug screening, a formed consent treatment agreement, look at prescription drug monitoring program, and coordinate with colleagues. This may not be what you're doing if someone's in your hospital setting at end of life or they're going to die, but I'm thinking about I take care of people that may live for years. And yes, they may have cancer, but they're still at the same risk to develop substance misuse issues as someone with non-cancer related pain. And some people might say, but they have cancer, we should give them whatever they want. We don't want to be treating someone's cancer-related pain with an opioid, have them develop an opioid use disorder, and then their cancer's treated, but now we have another chronic serious illness. And you want to make sure that if you work in the inpatient setting and someone's going home on opioids, or you work in the ambulatory setting, if that person is not at end of life and death is not imminent, you want to make sure naloxone rescue kits are prescribed to all patients who may be diagnosed with a substance use or opioid use disorder, may be on medications for opioid use disorder, may be on high-dose opioids, which the Centers for Disease Control say more than 50 milligrams of morphine equivalent daily, at risk for overdose, be frail, organ dysfunction, or have safety risks at home. So these are people with children or young adults in the home situation. So I'm going to briefly talk about some other analgesics to consider. These are usually reserved for when people have refractory pain. They're not something that I even use on a regular basis in my practice, but it's something that you may, of course, want to coordinate with a person in pain management, palliative care. And this one of them is ketamine, and this is an NMDA antagonist that's commonly used as an anesthetic agent, but it's used for pain in low dose. And you might be seeing it if you work in an inpatient setting, used in the perioperative setting to try to decrease the use of opioids. And so it's also seen to be possibly effective for severe opioid refractive pain. And regimens can vary and can be infusion, intermittent bolus. There are some oral troches, some intranasal. It can cause sedation, nausea, vomiting, variable blood pressure, tremors, seizures, psychomimetic effects. And we may need to treat it with a low-dose antipsychotic or benzodiazepine prior to initiation as needed. I'm not going to talk more about this, but there are articles about this. You might want to check in your setting to see if it's even an option. We often may use this when we have someone who's on high-dose opioids in the ambulatory setting, comes in with refractory pain, maximal opioids, and almost as kind of like a reset. Will ketamine actually help to almost reset to decrease the tolerance to the opioids so it might be responsive? Now, lidocaine is we often think about it in the cardiac setting, right? It's part of our, ACLS protocol. It's a sodium channel blocker. At lower doses, it's been shown to be efficacious for acute postoperative pain, some neuropathic conditions, some chronic inflammatory conditions, and possible efficacy for opioid refractory cancer neuropathic pain. So infusion times can vary. It can be, from a couple hours to a couple days, and analgesia can last for several days to weeks after the infusion. It can cause nausea, vomiting, diarrhea, perioral numbness, and of course, if it's being administered in the inpatient or ambulatory setting, you're going to watch for any type of cardiotoxic effects, but usually this is not going to happen at the doses that are utilized for pain. Now, intrathecal drug delivery systems, and this is also called IT pumps, this is generally used for intractable pain because this is actually a surgically implanted pump with medication delivery to the cerebral spine, cord fluid in the subarachnoid spaces. So it allows for much lower doses of medication, thus may limit side effects. And the medications utilized could be morphine, hydromorphone, fentanyl, baclofen, bupivacaine, clonidine, sacuntide. But careful selection is necessary and may be limited by patients' life expectancy. So, someone who may only have a life expectancy of like 2 to 3 months, that may not be appropriate, given the fact that a person needs to be evaluated, they need to do a chest trial, it's going to be surgically implanted. So let's go back to the case where ML was treated with an extended release opioid every 12 hours. The pregabalin was titrated for the pain to the hands and feet and was affected. She had radiation to the vertebral spine, which decreased some of the pain. However, she had several periods a day where she had worsening pain, especially when participating in activities of daily living. So many of you probably treat breakthrough pain and don't even think about it, but breakthrough pain, really the definition is an increase in intensity when baseline pain is controlled on a regimen of analgesics. And this is challenging. I find this challenging in the sense that I have people on extended release opioids. I may be treating with immediate release opioids for breakthrough pain, but they take the immediate release opioids around the clock. But then if I try to titrate the extended release opioids, it seems like they still don't decrease the use of the immediate release opioids. But the cause can be end of dose failure that you sometimes see with your extended release opioids. It can just be incident pain, like when someone does physical therapy. Or it can just be unknown causes. And we often see this with neuropathic pain where people talk about just onset of severe burning, shooting pain that comes out of nowhere. Now, the general principle is to use 10 to 15% of the total daily dose of opioids as the breakthrough medication. So, for example, if they were on morphine 100 milligrams daily in extended release, then 10 to 15 milligrams of morphine would be the dose for the breakthrough. The general practice is to use the same medication for breakthrough medication as the long-acting agent, except for methadone, or to consider your rapid onset opioids, such as your buccal fentanyl. There's not a lot written about this much anymore. I mean, back in the early 2000s, there was a lot more written about it, but it's something that we think about. Now, if I have someone who's on extended release opioids and their disease is progressing, and all of a sudden they've gone from using 3 doses of a breakthrough medication a day to using 6 or 7, then I might want to increase my extended release. So over time, ML's disease progressed, pain continued to worsen despite the use of opioid, corticosteroid, and neuropathic agent. She developed worsening side effects from the opioid when the dose was increased. So this is when we need to think about opioid rotations. So opioid rotation is, changing from one opioid to another. And the reason you may do this is the pain's controlled, but there's adverse side effects that are intolerable. Or the pain's not adequately controlled, but dose escalation is not possible due to side effect. Or it's not controlled even though you rapidly titrated the opioid. So how do you do this? Okay, really you're going to use this equal analgesic table, which I did not include here in this presentation, but you will see it in the references and using that National Comprehensive Cancer Network article. But you'll look at that table to calculate your new dose, recognizing this is only a guide and that you're usually going to decrease the dose of the new agent to 50 to 75% of what the equal analgesic dose is, because there may be what's called incomplete cross tolerance, meaning that this person may respond much more to the new opioid than to the one previously used. And if you're rotating to transdermal fentanyl and you're using the dosing guidelines that are published, there's usually no need to reduce the dose because this has already been calculated in. However, if someone you might want to consider further dose reductions if the person is older, has organ failure, less if the pain is severe. Now, if I was transitioning from a fentanyl patch to an oral opioid, I may be very careful because I may not know how much of that patch is actually being absorbed, even though there's literature that says it's absorbed just the same in cachectic populations. I question that, so I may reduce the dose even more. And you want to monitor for excess sedation or adverse effects of the new opioid. So ML was hospitalized due to uncontrolled pain, secondary to disease progression, despite opioid rotation and use of breakthrough medications. She could no longer tolerate oral medications, was eating poorly, and could no longer get out of bed without assistance. She was started on IV analgesics at equal analgesic doses. And that's when we think about what do we need to do to titrate opioids. And so really you're going to calculate the total amount of supplemental medications in the last 24 hours. This would be her breakthrough, and convert it to your fixed schedule administration. And this would be, even if you're using an infusion. And you might titration of the dose increment or your breakthrough pain of 30 to 50%, usually is considered safe. But you may need to titrate 50 to 100% daily in those with severe pain or in a moderate setting. And in someone in a hospital setting that has severe intractable pain, you might want to repeat your dosing every 30 minutes until the pain is relieved, and then calculate your maintenance dose. Now, this may not be possible unless you're in a setting where you have a really low nurse-to-patient ratio. And so that's when you may need to say, can a clinician who can actually administer opioids at the bedside be available? So in this case study, the opioids were titrated and decision was made to switch to comfort-focused care. She decided that pain control was more important than her ability to stay alert, and the decision was made to initiate a continuous infusion of opioids to promote comfort, even if it risked her being more sleepy or sedated. And she was transferred to the inpatient hospice where the pain was managed, and she died on the unit. So when we think of some of the basic key principles to analgesic implementation, you want to choose the right medication for the pain type, whether it's mild, moderate, severe, the right medication for the type of pain, nociceptive versus neuropathic. You want to combine NSAIDs, if not contraindicated, with acetaminophen, opioids, and adjuvants, as this may reduce the opioid dose. It may be opioid sparing, and because it works on different receptor sites, you may maximize pain management. You want to choose the right dose and titrate to adequate analgesia. You want to look at the patient's history to avoid cookbook dosing. Now, that doesn't mean that you won't look at what are the recommended beginning doses, but if someone comes in with chronic pain already on chronic opioid therapy, then you may be using different dosing if you're starting even an IV infusion. So you usually want to start opioid therapy with short-acting or immediate-release agents and then transition to controlled-release opioids. And patient with pain around the clock, you need a base of controlled-release opioids with short-acting opioids for breakthrough or incident pain. You want to stay ahead of the pain. Around-the-clock dosing of this pain is expected to last more than 24 hours. And I'm talking about this is not in your acute care setting post-operatively where you feel that pain is going to rapidly improve as day goes on. You want to use breakthrough analgesia before the pain escalates. And, when we say let's use breakthrough every 6 hours PRN, if someone has normal renal hepatic function, most breakthrough medications or immediate release opioids may not even last more than 3 hours, and IV doses may need to be dosed every 2 hours. When you're in the inpatient setting, it's really hard, and I know because I've worked as a registered staff nurse, although quite a long time ago. You want to avoid using the phrase, your medication's not due yet. Yes, you may feel like maybe it's a patient drug seeking, but is it drug seeking, or is it they're just not getting the analgesia they need at the right time? And you want to educate patients about how to ask for medications for breakthrough analgesia. Although oral is the preferred route, we may need to rotate to transdermal, rectal, vaginal. Rectal, vaginal is not widely used in the United States. intravenous and subcutaneous as the disease progresses. Really should avoid intramuscular as a delayed absorption, fibrosis, abscess, and then neuroaxial analgesia when we think about epidural, intrathecal for refractory pain or intolerable side effects to other opioids. And really, you want to be able to discuss the effects of unrelieved pain, ask patient to report side effects, anticipate and treat side effects of opioids, which we didn't talk about in this presentation but will be discussed later, and teach about analgesia because you have to know it to teach it. So really the take-home points are to treat pain aggressively and advance disease with the use of adjuvants and opioids, utilize universal precautions for opioid management in the ambulatory setting, and consider use of rapid opioid titration when pain is severe. Use opioid rotation when pain remains intolerable or side effects uncontrolled. Use adequate breakthrough medications at adequate doses, and be prepared to utilize different routes of administration as disease progresses and toward the end of life.